All right, we are going to get started. Good evening, everyone. Thank you so much for joining us. We're here tonight for our Upper Peninsula Health Science and Medicine public lecture. My name is Steve Elmer. I'm an associate professor here at Michigan Tech in the Department of Kinesiology and Integrative Physiology. Tonight's lecture is organized by our department along with the Health Research Institute. I have just a couple of quick announcements before we welcome in and formally introduce our keynote speaker for tonight, Dr. Barry Franklin. We have a great turnout. Our audience tonight includes a combination of students, staff, faculty. We have clinicians and community members from across our rural Upper Peninsula region here. Folks from Northern Michigan University, Gogebic College, Lake Superior State, and of course, Michigan Tech University. I also want to give a special welcome to some friends, colleagues, guests, and students from downstate Michigan, from Alma College, Central Michigan University, Wayne State, Oakland University, Michigan State, and Central Michigan, if I didn't mention them as well, and a few others from Skidmore College, St. Ambrose in Iowa, and even on the registration, we have a couple of Canadians here from the Sault Ste. Marie area. So we really appreciate the enthusiastic turnout. We're looking forward to tonight's public lecture. Just a couple of housekeeping things. Please double check that your microphone is muted and that your camera is turned off. We would ask that if you have any questions, you can hold those to the end. My colleague Isaac Wiedig, who's a doctoral student here in our department, will manage the chat feature and answer any, have those questions directed to Dr. Franklin here at the end. We would also ask that you only use the chat feature for questions and not any background conversation. It'll make our job a little bit easier. I also wanted to emphasize that tonight's lecture is part of a strategic initiative here to help strengthen our academic and clinical partnerships in our rural area so that we can ultimately advance healthcare, health science, research, and health education. So with that, I'd like to formally introduce Dr. Barry Franklin, who's our keynote speaker tonight. Briefly here, Dr. Franklin is currently the director of Preventive Cardiology and Cardiac Rehabilitation down at Beaumont Health in Royal Oak, Michigan. He's also a professor of internal medicine at Oakland University in their School of Medicine. He's been the past president of both the American College of Sports Medicine as well as the American Association of Cardiovascular and Pulmonary Rehabilitation. He's the past editor-in-chief of the Journal of Cardiopulmonary Rehabilitation and Prevention, and he's currently on the editorial board for over 15 scientific and clinical journals. To date, he has authored, co-authored, and edited more than 700 scientific and clinical publications, including 26 books. I did also want to mention he does have a book he's promoting right now. Here, if you can see this on the screen. This is timely. It's a home-based cardiac rehabilitation pamphlet and booklet for patients and clinicians, helping patients help themselves. Finally, I would also mention that to date, he's given over 1,000 invited presentations at local, regional, state, national, and international to audiences. And for our students that are joining us tonight, Dr. Franklin is very passionate, enthusiastic about helping inspire and train the next generation of both scientists and clinicians. So while we're here virtually, please join me in welcoming and give Dr. Franklin a warm round of applause. I will turn it over to you, Dr. Franklin.
Thank you, Steve. Good evening, everybody. It's a pleasure for me to be here. I'd like to especially thank Dr. Elmer for his invitation and for coordinating the logistics of this presentation both tonight and tomorrow. It really is a terrific opportunity for me to talk on a topic that I'm really passionate about, and that is preventive cardiology and lifestyle medicine. If you want to leave in 30 seconds, I guess my take-home message is we need to promote preventive cardiology, lifestyle medicine to a far greater extent than we're doing invasive, expensive procedures to counter coronary artery disease. When I think of prevention and preventive cardiology, I'm reminded of an email I got from a dear friend in India a couple of years ago that I want to open up with. It was a congratulatory note, and you can see it here on this slide. Dr. Franklin, I was so pleased to see your famous quote on our European Preventive Cardiology conference bag. Congratulations, Dr. Contractor, Mumbai, India. Hell, that's not my quote. That quote came from Benjamin Franklin. And as a matter of fact, an ounce of prevention is worth a pound of cure back in the 1700s. And what you may not know about that quote is it had nothing to do with health. It had everything to do with preventing fires, yet it's become widely known, and occasionally I see I'm given credit for a quote that really doesn't belong to me. When I give a talk like this, oftentimes before a lay audience, I ask people to raise their hands if they think they've got cardiovascular disease. And oftentimes middle-aged and older individuals say, no, I haven't had any problems, I'm fine. The fact of the matter is, the Cleveland Clinic, at a landmark study nearly 20 years ago, using what's called intravascular ultrasound, showed and came to the sobering conclusion that about 85% of all US adults over the age of 50 already have atherosclerotic coronary disease. So my late friend I. Martin Grace, a cardiologist in Chicago for many, many years, said, for me, he said, the question isn't whether middle-aged and older adults have heart disease if they grew up on McDonald's, Ben & Jerry's, Big Boy, Church's Chicken. They got coronary disease. It's as simple as that. The real question today is, how do you prevent acute catastrophic cardiovascular events? So the take-home message, if I see a 55 or 60-year-old person sitting in front of me who says they've got no history of coronary disease, I'm 85% confident if we look at those coronary arteries via intravascular ultrasound, we're going to find disease already present. The real key, however, is this: how do you prevent acute catastrophic events? The kind of events that killed the beloved newscaster Tim Russert or the fine actor James Gandolfini. Recognize, as we set the stage for this talk tonight, that primarily men aged 60 plus or minus 5 years are in that high risk cohort of sudden cardiac death. We lose over 300,000 people every year to acute coronary syndrome, sudden cardiac death, 850 Americans per day. So the devastation is huge, and oftentimes it's when people are in their most productive years, late 50s, early 60s. The fact of the matter is, as you see in this next slide, we lose over 800,000 people to cardiovascular disease each year, and worldwide we lose 17.3 million, making it one of the biggest societal killers. For 50 years now, I've pondered the question, what can we do? How can we help people to avoid being in these fatalities every year? This article got my attention, published in the prestigious New England Journal of Medicine 2007, because it addressed a question that many of us have had. When we talk about atherosclerotic cardiovascular disease, what are the factors that contribute to it? And in this Shattuck lecture, Stephen Schroeder, University of California, San Francisco, really boiled it down to 5 factors. He said social circumstances, environmental exposure, healthcare access or lack of access, behavioral patterns, and genetic predisposition all contribute in our society to premature death. But it's very apparent from this figure that the single most important determinant are the behavioral patterns of people on a day-to-day basis, or I'll change it, or I'll phrase it, the choices they make on a day-to-day basis. My own bias is very strong. We've got to do a better job helping them make the right choices on a regular basis. This evening, I'm going to cover 5 topics that I think are the primary topics in this area, preventive cardiology. I'm going to start with the hazards of cigarette smoking and secondhand smoke. Then we'll move on to cardioprotective medications. How effective are they? Number 3, what does the evidence say about dietary strategies? How effective are they in reducing initial and recurrent cardiovascular events? Then we go on to walking, speed, distance, physical activity, cardiorespiratory fitness, which we express in units called metabolic equivalents, mortality. I get the question every day, I want to do high intensity interval training. Is this something we should be recommending? And lastly, what's the relationship between cardiovascular disease, genetics, and lifestyle patterns? And can healthy lifestyle factors positively influence life expectancy? And I hope to do all this in the next 50 minutes. Here's a diagram, and it'll be apparent. I like simple things when I teach. This was a diagram that was a figure that was put together by Darius Mozaffarian when he was at Harvard. He published in the prestigious journal Circulation in 2008. And what he said is at the foundation of that triangle or pyramid, you've got three unhealthy lifestyle factors: poor diet, physical inactivity, and cigarette smoking. Those lead to a host of conventional risk factors, including diabetes, obesity, low fitness, high cholesterol, hypertension, which then lead to inflammation and early vascular disease. Ultimately, then, the clinical endpoints are shown on this slide, and you can see them, and ultimately death, culminating in death. What you see here, this vessel right here that I've shown, is actually the cross-section of a coronary artery of a 37-year-old woman who died of an acute myocardial infarction. So this is the foundational factors that over time lead to the major killer and crippler in our society, atherosclerotic cardiovascular disease. I want to start here, however, with cigarette smoking because it's oftentimes not emphasized enough. Here's an old slide that I had when they first started promoting cigarettes. And it's interesting to note that they oftentimes used movie people or physicians to promote presumably the wonderful effects of cigarette smoking. Ronald Reagan, Robert Mitchum, actors were oftentimes recruited to promote this for the cigarette companies. Here's a classic figure by a very famous artist by the name of Frank Netter. And if you look, there's a lot in this figure. Basically, what you see is a salesman walking out of a restaurant after a heavy, high-fat, high-calorie meal. He's carrying a heavy sales bag. There's snow outside. The wind is blowing. He's walking up steps, and he suddenly clutches his chest due to anginal symptoms. And if you look closely at this figure, right at his feet, he's just dropped his cigarette. This got my attention early in my career. Someone gave me a copy of the obituary, and I followed this guy in his career. Wayne McLaren was the rugged Marlboro man who died at the age of 51 of lung cancer. He'd been smoking for more than 25 years. And he said at the end of his life, my habit had caught up with me. He said, I've spent the last month of my life in an incubator, and I'm telling you, it's just not worth it. He went on to plead with the Philip Morris Company not to advertise cigarettes. And even today, we still run into problems in terms of marketing, who they're marketing to. You said to me, Barry, give me the classic studies that were done in this area. This is one I oftentimes cite. It was singularly impressive, published in the British Medical Journal 2004 by Dahl and colleagues. What got my attention here is they studied 34,000 British physicians, all men, over a 50-year follow-up period, and had about 96, 98% follow-up. It was meticulously done. You say to me, what did they find? In a nutshell, they found it's never too late to quit smoking. Number two, there's an age that if you can quit smoking at, there appears to be little or no harm. And the most devastating factor that I found is shown in this slide. When you compare thousands and thousands of physicians in this study, you compare smokers versus non-smokers. Smokers died on average 10 years earlier, 10 years subtracted from their lifespan. But if you go to the far left on this graph, and I've circled it, under the age of 40, there appear to be little or no deleterious effects. Now, I'm not telling you to wait to 39, tell the patient, and then to stop cigarette smoking. But what I'm saying to physicians and public health people, if we can get people even in their 30s to stop cigarette smoking, and they say, well, I've been smoking for 15, 20 years already, the fact of the matter is we can still do a tremendous service for public health. Some people, however, looked at this study and said, I don't believe it. Well, I thought it was beautifully done. Is there another study that substantiates this? And the answer is yes. Published in a decent journal a few years later called the New England Journal of Medicine. In this study, what they did was the US National Health Interview Survey. They looked at over 200,000 men and women, followed them over a large number of years. You said to me, Barry, what's the take-home message? The take-home message in this study, which is even worse, life expectancy was shortened on average, 11 to 12 years among current smokers as compared with those who never smoked. And cessation before the age of 40 reduced the risk associated with continued smoking by about 90%. Clinically, there's a problem with patients because when I see a smoker, once in a while, somebody will say to me, well, I had an Uncle Jesse and he was a cigarette smoker and he lived to be 83. And the point I make to them is don't place your decisions for your lifestyle on one person. I study thousands of people. When you study thousands of people like I do, on average, they lose 10 to 12 years by cigarette smoking. In fact, there's nothing more significant, health-wise, in my humble opinion, than getting a smoker to stop smoking. Here's something else that a lot of people don't realize, even today. This was back in 2005. Stan Glantz, who's done more work in this than any other researcher in the world, looked at cardiovascular effects of secondhand smoke. In a nutshell, what did he find? Secondhand smoke increased the risk of coronary events and cardiac events by about 30%. So a woman who lived with a man who was a cigarette smoker or vice versa, or somebody who worked with people who smoked, on average, even after adjusting for all the confounding variables that could lead to a difference, they found simply breathing somebody else's secondhand smoke increased the risk of cardiac events by about 30%. I've been involved in human resources and all kinds of concerns where employees said, I got a right to smoke, and somebody else says, I got a right to breathe clean air. And these data and others I'll show you say that the latter is the correct person. They should have a right to breathe clean air because we have unequivocal evidence, as you'll see in the next series of slides, that secondhand smoke can lead to acute coronary events. What about cities? What about countries that adopted smoke-free legislation and then they followed up acute coronary syndrome events? Was there any difference? One of the first ones that got my attention was this, New England Journal of Medicine, 2008. March 2006, smoking had been prohibited in all enclosed public places throughout Scotland. So they said, let's look and see what happens to acute coronary events subsequent, before and after the smoking ordinance. Look at these data. Overall, the number of admissions for acute coronary syndromes in Scotland decreased a whopping 17% as compared with a 4% reduction in England, which had no such legislation. Even if you look at Scotland over the previous decade, the average annual decrease was just 3%. All of a sudden, they got a 17%, and the maximum ever in Scotland was 9%. So they concluded unequivocally that by having a smoking ban, we're going to prevent heart attacks in a large segment of the population. And it turned out in this study, 67% of the decrease involved non-smokers. Say to me, Barry, show me the data. Here are the data. Here are the data for acute coronary admissions for acute coronary syndrome before the legislation, after the legislation. Every month it was lower. There's no question in my mind that breathing somebody's secondhand cigarette smoke can be a trigger for acute coronary events. This study got my attention. Gilpin County, Colorado, once again, Stan Glantz, Ph.D. What he did, he published this in Circulation 2013. There's a city, Gilpin County, Colorado, very large casino presence. The people who run the city decided many years ago, we're going to have a smoking ban. We're not going to do it in the casino. We can't do it in the casinos, but we're going to have a smoking ban throughout the city. And let's see if it improves the health of our citizens. What did they find? Listen to this very carefully. Initial implementation of the smoke-free law, which exempted casinos, they didn't do it in casinos, was followed by a 23% drop in ambulance calls from locations other than casinos but no significant change in calls from casinos. These data were so compelling 2 years after they found this. They said, you know what? We got to do the casinos as well. Every place has got to be smoke-free in Gilpin County, Colorado. The following year, the law requiring smoke-free casinos taken into effect was followed by a 19% drop in ambulance calls from casinos for heart problems, but no change in calls originating outside casinos where it was already in effect. This really got my attention. Published the European Journal of Preventive Cardiology. What they looked at is the STEMI registry. STEMIs are huge heart attacks. They cause the biggest amount of damage. Bremen, Germany implemented a smoking ban, and they looked to see if the number of STEMIs was reduced. They found it was reduced very significantly, especially in non-smokers. They concluded these results may be explained by the protection of non-smokers from passive smoking and the absence of such an effect in smokers by the dominant effect of always being exposed to that active smoking. You say, show me the data, here are the data, and they're pretty darn compelling. Here, if you look, you can see when they implemented the smoking ban, right away, the total number of heart attacks decreased. And the primary decrease, as you see here, was in non-smokers. Really sobering. Topic number two of the five, cardioprotective medications. What do you need to know here? I deal with this on a day-to-day basis and have for many years. The four major categories that we look at are aspirin, statins, beta blockers, and ACE inhibitors to prevent initial or recurrent cardiac events. I've been studying these for many, many years. If you say, how effective are they? On average, the reduction, each one causes an 18 to 44% reduction in initial or recurrent cardiac events. Probably the most potent out of all these is the statins. The average decrease is about 23%. Aspirin, we now realize, we used to recommend it for primary prevention. Now you've got to be really at high risk to take it for primary prevention. In secondary prevention, it's almost routinely recommended. Here's something else people don't realize. Doctor prescribes medication, we assume everybody takes it. No, they don't. Everybody doesn't take it. This was done at Duke, one of the best cardiovascular programs in the world, by Kristen Newby several years ago, looking at adherence to doctor prescribed medications. What did she find? Nearly 30% of the patients who were prescribed aspirin, statins, beta blockers weren't taking them. That includes beta blockers, lipid-lowering therapy, or combinations of these drugs. What's the penalty, you ask me? The penalty is this. Ho published in American Heart Journal the fact that people, if they're prescribed beta blockers, they're not taking beta blockers, they show a 50% increase in all-cause mortality as compared with those who are taking it. Those who do the same thing with ACE inhibitors, a 74% increase in cardiac events, and statins an 85%. So the point is, don't assume just because it's prescribed, people are taking it. And really good doctor offices today, in my opinion, have a PA or a nurse clinician really monitoring this stuff. And if they're not taking it, why? Is it the cost? Is it adverse effects? What is it? And we've got to try to resolve some of those issues. This is a rather devastating picture. It was an early slide I had in my career, but it made a very strong point. The top right is actually a good friend and esteemed colleague of mine. His name is William C. Roberts. Dr. Roberts recently turned 88. I sent him a birthday card. He's still working full-time. He's the editor of American Journal of Cardiology, and in his spare time, he serves as the editor of the Baylor University Medical Proceedings. He teaches the fellows, he teaches the residents. This got my attention because it looks so ugly. And I remember seeing this case report, and I looked at this guy, and then I was shocked to find out this guy was 36 years of age. This guy had had 3 previous heart attacks, if you read the case report. And what you see here are really a extreme hypercholesterolemia, which has led to malignant atherosclerosis. These are subcutaneous cholesterol deposits throughout the body called xanthomas. It really highlights the fact that high levels of cholesterol are intimately involved. Roberts says, and some people debate this, but if you're going to pick one risk factor, get that cholesterol controlled. I sat next to him on a plane one time. He said, I said, what one thing do you want me to remember? He said, of course, the rule of 40. I didn't know what he was talking about. So I said, Dr. Roberts, I don't know what the rule of 40 is. And with that Baylor accent, he said, Barry, whatever the patient's cholesterol is, if it's 280, you take it down to 240, you cut the risk in half. Take it from 240 down to 200, you cut the risk in half again. Take it from 200 down to 160, you cut the risk in half again. So roughly, he said, based on 50 years of research experience, for every 40 points you lower the total cholesterol, you cut the risk of a future heart attack in half. He was very, very vocal. He's been very vocal, and he's not a paid spokesperson for Pfizer or Merck or anybody, but he's a big proponent of the cholesterol lowering drugs and statins. Highlights the fact that total cholesterol is typically reduced by 22 to 47%, LDL by 27 to 60%, HDL smaller increase, favorable increase, about 7%. He also taught me what's called the rule of 5 and 7. And that is when you want to further lower the total cholesterol and the LDL cholesterol, by doubling the dosage, you cause about a 5 to 7% further reduction in total cholesterol and LDL. So if the patient's on rosuvastatin 10, you take that to rosuvastatin 20 because you want to get it down a little bit more, you're going to get about a 5, 7, maybe 8% additional lowering of the total cholesterol and LDL cholesterol. Say, show me the most recent study. This is one of the largest trials, the Heart Outcomes Prevention Evaluation. I always like studies published in New England Journal because they're meticulously done. They account for confounding variables. In this case, they looked at a large ethnically diverse population. They looked at 4 major outcomes, and you can read them yourself on this slide. They compared those who took rosuvastatin or Crestor, and it was a small dosage, I think it was 10, versus a lookalike placebo pill. Looked exactly the same, and only the outside Data Safety Monitoring Board knew what they were taking. They followed these patients over a number of years. Overall, those taking the Crestor showed about a 27% lower LDL than the placebo group. And as you look at individual outcomes, treatment with rosuvastatin at a fairly low dose, 10, resulted in significantly lower risk of cardiac events in each of these panels, 25 to 37%. So statins unequivocally work. I'm not a paid spokesperson for any of these. I take a statin myself. For people who may be at risk for cardiovascular disease or with known cardiovascular disease, statins are one of the drugs of choice. And in general, the general feeling right now is if the patient has had a known cardiac event and they can tolerate it, put them on a high intensity statin at a higher dose. So most of our cardiac patients are on rosuvastatin 20 or 40 or on atorvastatin or Lipitor 40 or 80. And you can see this is one of many studies showing better prognosis, lower mortality with high intensity, higher dose statins. Once again, if they can tolerate them, if they don't develop liver enzyme abnormalities or rhabdomyolysis. Very hot area right now is a new injectable drug to lower cholesterol, which is very, very potent, taken once or twice a month. They're called PCSK9 inhibitors. If you look at the left-hand panel, this compares placebo plus statin therapy plus a PCSK9 plus statin therapy, and look what the latter combination did. I've circled it here because if you look, you'll see it lowered that LDL cholesterol an additional 52 to 61%. Does that transform to lower coronary events? Yes, unequivocally. Look here, overall, those placebo versus the PCSK9 inhibitors, about a 50% reduction in subsequent long-term cardiovascular events. What's the downside? The drug is very expensive. Many insurance companies won't cover it. The doctor's got to show that I've tried all these different statins at varying dosages. The patient's either intolerant to it or whatever to justify it. They initially came out very, very expensive, $1,000, $1,500 a month. The costs are going down more and more. We talk about drugs. Another question I get from patients all the time is, what should my resting heart rate be and resting blood pressure? My answer in a nutshell, based on lots of studies, is lower is better. Lower numbers associated with longer lives. This study, European Heart Journal 2007, looked at a large number of patients in France, post-MI patients, taking beta blockers. And what they found was that those patients who took beta blockers, the lower their resting heart rate, the better their prognosis. And in fact, they found that each 10-beat reduction in resting heart rate brought on by beta blockade appeared to reduce the relative risk of death, cardiac death, by about 30%. So I tell our residents, fellows, and nurses, you got a heart patient, he's walking around with a heart rate of 90, he's got no business walking around with a heart rate of 90. We've got to get his beta blockers under better control. Certainly weight loss, certainly exercise. Exercise, in my experience, typically lowers the resting heart rate after 2 to 3 months by 8 to 10 beats. So that should transform also to about a 25-30% reduction. This study in the general population showed, you look at large numbers of men and women published in the Mayo Clinic Proceedings, those who have slow resting heart rates, right around 60 or lower, have far fewer coronary events than apparently healthy individuals who die of cardiovascular disease, who were walking around with resting heart rates of 85, 90, 95. Researchers believe probably that slower heart rate exerts less stress over time on blood vessels, and that may be the reason. What about blood pressure? For many years, I told our cardiac patients, I want to get your pressure under 140 over 90. I was wrong, and lots of people were wrong. When the SPRINT trial came out, once again published New England Journal of Medicine, showing the lower the blood pressure, the better the prognosis. They looked at over 9,000 people with hypertension, all above 130, some a lot above 130, at increased cardiovascular risk, but none of these patients had diabetes, and I'm not sure, at least overt or apparent diabetes. They randomized into 2 groups: systolic blood pressure, aggressive, less than 120, or a target of less than 140, which I and many other people said that's where you want to be. They followed these individuals for the next 3.5 years. There's an outside data safety monitoring board that compares the groups. And if there's such a difference from one group to another, that data safety monitoring board will say, we got to stop this study. It's as simple as that. This group is being unfairly penalized. They stopped this study early because it was due to go longer, because they found that the intensive group, that is, who got their pressures down to 120 versus 140 or over 140, showed a 25% reduction in acute coronary events. Say, show me the data. Here are the data. And the major point I want to make on the left-hand slide is that the standard treatment, most of the patients were taking 2 drugs, 1.8, 1.9. For the intensive treatment, maybe 3 drugs, maybe a beta blocker, maybe diuretic, maybe an ACE inhibitor, whatever. And if you look here, the intensive treatment, clearly the hazard ratio of 0.75, showing about a 25% reduction in overall cardiovascular events. Topic number 3, evidence-based dietary strategies. What do you need to know? I mentioned Dr. Bill Roberts. I'm a friend of his. I've admired him for years. 30 years ago, people said the guy's nuts. He came out with a quote the other day at a big scientific meeting. Our excessive intake of meat is killing us, he said. We fatten our cows and pigs, we kill them, we eat them, then they kill us. How sobering. By the way, in the lower left-hand corner, that's Denny's Beer Barrel Pub in Pennsylvania, 9-pound burger. If you could eat it in an hour, you don't pay the $24.95. They've had very few people been able to do that. This study got worldwide attention. Archives of Internal Medicine, they looked at 37,000 men from the Harvard Health Professionals Follow-Up Study and more than 83,000 women from the Harvard Nurses Health Study who were followed for almost 3 million person years. These are powerful, powerful data. Take-home message: first, large-scale prospective longitudinal study shows that consumption of processed, unprocessed meat associated with increased risk of premature mortality from all causes, as well as cardiovascular disease and cancer. I took particular interest in this because I've tried to follow a Mediterranean diet. I can't go pure vegetarian. Uh, Yet I want a heart healthy diet, and this is the one I've selected. This paper had a lot of influence on me. It was done in Spain. They had multiple centers. These people were all at high risk for cardiovascular disease. Um, this study was also stopped on an interim analysis after a median follow-up of about 4.5, 4.8 years, and it was stopped because among persons at high cardiovascular risk, as you can see here, a Mediterranean diet supplemented with mixed nuts or extra virgin olive oil, much lower hazards than those patients following a control, usual low-fat diet. So this really suggests that you can get a very sizable reduction in future coronary events simply by eating some fish, chicken, turkey, lots of fruits and veggies. They allow wine and so on and so forth in this diet. So I think it's very realistic for many of the people I see with coronary disease. This study looked at the EPIC Oxford study, looked at patients who came into hospitals in the UK, and they divided them into vegetarians and non-vegetarians based on a careful analysis of their dietary habits. What did they find? They found, and this makes sense to me, that vegetarians had a 32% lower risk of ischemic heart disease than did non-vegetarians, which was only slightly attenuated by adjusting for all confounding variables. So what I'm saying is the hazard ratio here is 0.68, indicating that if you're a vegan, for the most part, you're gonna experience a 32% reduction in acute coronary events, even after adjusting for age, body mass index, smoking status, or other coronary risk factors. So when patients say to me, when I see data like this, you're gonna give me one thing to do, what's that for diet? My answer, I may be wrong, but my answer is I want you eating 6 to 7, maybe 6 to 8 servings of fruits and veggies every day. And I don't want you to leave the darn breakfast table unless you've had at least 2. Many times, if I have breakfast, it's Cheerios with blueberries on it, a small glass of V8 low sodium vegetable juice, and a banana. So the banana, V8, blueberries, I'm walking out, it's like a horse getting out of the gate. I want our patients to leave saying, geez, okay, I got to eat 3 or 4 more servings of fruits and veggies before I go to sleep tonight. These are bad for you. Trans fats, in my opinion, they're worse than saturated fat. They're found in fried foods, a lot of commercial baked goods, right in the bakery, processed foods, and margarine. They have adverse effects on LDL and HDL cholesterol levels, Lp(a), triglycerides, indices of vascular inflammation, including interleukin-6, tumor necrosis factor, C-reactive protein. They also increase coronary disease and diabetes. So I strongly urge patients to stay away from baked goods. Trans fats are bad. The American Heart Association recommends limiting the amount of trans fats to less than 1% of daily calories. That means if you consume 2,000 calories, no more than 20 of those calories should come from trans fats. That's less than 2 grams of trans fats a day. Here's something that many docs don't know, and the nutritionists have been very helpful in updating me. Sometimes a food package says 0 trans fats. That can be very misleading. Why? Because the nutritionists have shown me that many of those fats, those foods that say on the package 0 trans fats, if you actually look at the content, there's 0.41 to 0.49 grams per serving. That's because the FDA allows them to put 0 trans fats if the trans fats is very low. They shouldn't be eating any more than 2 grams of trans fats a day. So that can be very misleading if you have a serving here, and a serving here, thinking you're eating 0 trans fats. So the best rule to tell patients is look at the labels. And if you see the word hydrogenated or partially hydrogenated, there is trans fats in there. Maybe it's 0.46, 0.48. So even though the label says 0, there is something in there, not a good food to eat. Salt, another problem. These are foods that are very, very high in salt in the American diet: breads and rolls, cold cuts, pizza, poultry, soup, sandwiches. The average American consumes about 3,400 milligrams of salt. That's twice the 1,500 milligrams recommended by the American Heart Association. So I sometimes see patients and they say, well, we don't have salt on the table. My answer is 80% of the salt you eat is already in the food. So just by eliminating the salt shaker, that's not going to do the job. You got to look at labels. You got to look at labels. Here's a great rule I was taught. Look at the milligrams of salt per serving and look at the calories per serving. You see it in the bottom corner here on the right. Remember the 1-on-1 rule. Ideally, a good food for your patients, somewhat heart healthy, is if the milligrams of salt is very similar to the calories per serving. Let me give you an example of a bad food. The middle one on the bottom, Campbell's soup, the original Campbell's soup, said 100 calories per serving, no fat, no trans fat. People say, wow, this is wonderful. There's no fat, there's no trans fat. It's only 100 calories. This is all American. This is great. Look at the milligrams of salt in the original Campbell's soup. It was 770. 100 calories, 770, almost 8 times the amount. This is where we run into problems with the American diet. If you're looking for a good recent paper on diet, go to the Journal of American College of Cardiology, Dr. Yu and colleagues, 2018, where they really reviewed the data on the benefits, limitations, and I found this graphic wonderful. And basically it says eat more fruits, veggies, whole grains. I had a local dietitian, when I talk about whole grains, I heard her say 15 years ago, and that's 15, 20 years ago is when I changed whole grains. The whiter the bread, the sooner you're dead. So I don't want you eating white bread. I want you eating whole grain bread, nuts, legumes, beans, and seafood, small portions. Decrease or eliminate processed meats, refined grains, sugar sweetened beverages, added sugar, foods with added sugars, trans fats, sodium, high levels of sodium, and saturated fat. Topic number 4, walking distance, speed, physical activity, fitness, mortality, high intensity interval training. By the way, that picture you see on the right is one I took several years ago. I remember vividly, I'm going to tell you the truth. I was exhausted, I was walking, and I was, and I could see something on the floor, maybe 100 yards back, but I couldn't tell exactly what it was. And I was definitely going to take the escalator as opposed to the steps. I was just exhausted. And then I got up there and I looked down at the floor and I made a sharp left and walked up the steps. So sometimes something as little as that can change people's behavior. Let's talk about walking speed, distance, fitness, mortality, in a very hot area that I'm asked about all the time, high intensity interval training. This is something I clipped off the internet in 2016, and it really got my attention. I thought our technological revolution has literally engineered physical activity, but in Japan, they've done one up on us. You don't have to stand in line to wait to go to in a store. They have chairs that automatically move. When you get down to the right, it bumps, and that tells you you can go in. I haven't seen them in the US yet, but I wouldn't be surprised if some stores get these. Sad. When we talk about physical activity, one of the early studies that got my attention was this one, published in New England Journal of Medicine, 1998. Let me set the stage for you. Over 700 non-smoking men, 61 to 81 years of age. They looked at the distance they walked each day, 12-year follow-up, over 200 deaths. What did they find? This study, New England Journal, came to the conclusion the mortality rate among those men who walked less than a mile a day was nearly twice that among those who walked greater than 2 miles a day. The conclusion was very carefully worded. Regular walking is associated with a lower overall mortality rate in older, physically capable men. I personally believe, and I believe the data are there, that this is not just an association, this is a cause and effect relationship. You say, show me the data. Here were the data from that classic study. Those men who walked less than a mile a day clearly had the highest mortality rate over that 12-year follow-up. Those who did 2 miles or more a day, so that could be broken up into half-mile, 10-minute walks, 15-minute walks, had much lower mortality. I've oftentimes wondered when I see a patient seemingly to walk very, very slowly, is there any relationship between walking pace and survival? Some very smart researchers published in the British Medical Journal 2011, they used the database, they used men studied in both Australia and New Zealand combined the data. They photographed them, they videoed them while walking. They did this beautifully. And what they found was there appeared to be a cut point. And those men who consistently walked at 2 miles an hour or slower, day-to-day activities, had the highest death rate. Anything above 2 miles an hour, the death rate began to drop. And interestingly enough, no men in this study were caught by the Grim Reaper or died over a 6-year follow-up if their average walking pace was 3 miles an hour or faster. Why is that? I'll give you my reason. I may be wrong. We know unequivocally, and I'll show you some data here later on this evening, that if we do a treadmill test on somebody and they've got less than a 5 MET capacity, they have a very poor prognosis. Dan Mark and others showed this in the Duke treadmill score study. If they're less than 5 METs total capacity, what this study says, if they're walking at 3 miles an hour, I know they're working at 3.5 METs day to day. If they're symptom-free, if they don't have any problems with that, I know if I take that person and put them on a treadmill, they're going to beat 5 METs. They're going to be over that 5 MET capacity because they're pretty damn close to it already. That, I believe, is the reason why people walking faster do better. So I routinely tell our residents, fellows, beyond vital signs, blood pressure, breathing, pulse, temperature, look at how fast the patient walks in your office. If he walks in at 1 mile an hour, that tortoise-like pace may provide the most telling vital sign of your physical exam that day. I tell patients, pick up your pace. You can disguise your exercise just moving or ultimately walking to at a faster pace. Ideally, 3 miles an hour or faster would be therapeutic and you'd be getting a workout in. Those who are going very slowly, I'm convinced, are heading in this direction, sadly. Implications for the medical community. We now realize then as we look at fitness levels and we divide them by quintiles, these are 3 of many papers that have shown that those at the greatest relative risk are in the bottom 20%. They're the least fit of the population. There's a huge drop here, and then there's modest drops thereafter with increasing levels of fitness. So the key is to get people out of the horrible fitness into the below average fitness. And if you can do that, there's a huge drop in mortality. Sometimes I see somebody and they tell me, Barry, I'm doing 50 miles a week and I'm going to go to 70 miles a week. I'm going to be much healthier. You ain't going to be much healthier. There's very little additional relative reduction in risk. The biggest risk comes at the bottom of the continuum, so to speak, the bottom 20%. What about the opposite? What about higher levels of fitness? Is the 15 MET person at the lowest risk? No, actually, they're not necessarily. This study shows there's a demarcation, and others have shown this, including our own work, that appears at around 10 METs. So if someone has a 10 MET capacity, you say, what does that transform to? It's completion of stage 3 of the Bruce Treadmill Protocol, 3.4 miles an hour, 14% grade. So if they can do that for 3 minutes without holding on for dear life, they generally do very, very, very well. And interestingly enough, as fitness goes up beyond that, there's very little, you can see it here, very little additional survival benefit. I don't disagree that the 15 MET person is going to beat the 10 MET person in a race. But in terms of survival, if that 10 MET person gets that 10 METs on a yearly stress test or 11 METs, overall, they've got about the best overall survival from exercise. What's the implication to me? If you're walking at a 2 mile per hour pace 3 days a week, that's 2 METs. If that's your exercise training workload, I'm betting you ain't going to get nowhere near 10 METs on your yearly stress test. So the goal is if you want 10 METs on your yearly stress test, I want you at least exercising 6, 7, 8 METs on a regular basis. It may take you 6 months or a year to get up there, but for heaven's sakes, don't start a program at 2 to 3 METs. And a year later, I go to the treadmill and I see what they're doing. They're on a treadmill at 3 miles an hour, 0% grade. That's 3 METs, a little over 3 METs. So we need to progress workloads to maximize the cardiovascular benefits. It's a paper I wrote with esteemed colleagues, Annette Wenger, Bill Bowden, in JAMA. The editors of JAMA, when the editors ask you something, you do whatever they want. The editors of JAMA asked us years ago in 2 pages, tell primary care docs around the country what they need to know about exercise in patients with stable ischemic heart disease. Take-home message from this paper is each 1 med increase in exercise capacity associated with about a 16% reduction in mortality. That compares very favorably with the survival benefit conferred by aspirin, statins, beta blockers, ACE inhibitors after acute MI. I'm not saying throw the medications out. I'm saying complement the medications by getting your patient's fitness up a MET or ideally 2 METs, which confers an additional 32% reduction in mortality. It's a very hot area. In my opinion, controversial. High intensity interval training. I get patients all the time, hey, should I be pushing at 95%? And if they're a heart patient, I answer very simply, no. I don't want you going to the YMCA and pushing at 95%. You've had a heart attack, you've got a compromised ejection fraction, and so on and so forth. The early studies used continuous training at around 70%. The Europeans started doing this high intensity interval training near maximum up to 90-95% of peak heart rate. The initial study that got worldwide attention was done by Wisloff and colleagues. They looked at 27 patients with stable post-infarction heart failure who were undergoing optimal medical treatment. In other words, they're on beta blockers, ACE inhibitors, average age 75. Look at this, ejection fraction, bad pump, 29%, VO2 peak measured was 13. That's a little less than 4 METs. They followed them over the next 3 months. They divided them into 3 groups, a control group, moderate intensity group, and high intensity interval training. What did they find? Well, not surprisingly, they looked at flow-mediated vasodilatation as an index of endothelial function. Controls showed no change in maximal oxygen uptake. Moderate continuous training showed nice improvement with both. But I'll admit, the high-intensity aerobic interval training showed the greatest improvement in blood flow, greatest improvement in VO2 max, also some improvement in the ejection fraction. So that was impressive. These were medically monitored patients. They were very carefully supervised. This report looked at all the studies to date in 2016, 10 studies, 472 patients, 218 high intensity, 254 moderate continuous training. They concluded overall high intensity training was associated with more pronounced gain in VO2 max. You can see it here, 1.78. That's about half a MET. In contrast, moderate intensity training associated with a more marked decline in patients' resting heart rate and body weight. Those are also important. There's no question in my mind that training is generally very safe, but this reiterated a concern that I had. The absolute risk for these cardiac patients, and these were small numbers, that was the limitation of this study, but the absolute risk for high intensity interval training in these cardiac patients was 1 event per 23,000 patient hours for moderate intensity, 1 event per 129,000 patient hours, almost 6 times higher in the high intensity group to get a little better improvement, maybe in vascular function or a half a MET higher as opposed to longer training, moderate intensity training. It's a paper we wrote a year and a half ago, published in American Journal of Cardiology. We reviewed every study to date, high intensity training versus moderate continuous training, and we found the same conclusion. High intensity training, about half a MET higher in VO2 max. My concern as a clinician, safety, we don't know the safety of repeated near maximal exercise in 50, 60, 70-year-old people, 85% of whom already have cardiovascular disease. I don't want them pushing to 90, 95% high, especially at the YMCA or an unsupervised non-medical settings. So we generally do not promote this for our patients, especially those at high risk. For military recruits who want to get in at 20, 21, 22 years of age, wonderful. If they have no structural cardiovascular abnormalities, it's a fast way to improve your fitness. But I don't think for high risk and people with known coronary disease. Last topic, genetics versus lifestyle, healthy lifestyle, and life expectancy. Reason I bring this topic up is sometimes I see a patient as well, I picked the wrong parents. My dad had a heart attack at 42. I'm 48 now. I've had a heart attack. So there's nothing that could be done. I've looked for a long time to see, is there a study that looked at genetics versus lifestyle? And there is, and it was done a few years ago. Published once again, New England Journal of Medicine. These are powerful data. Genetic risk, adherence to a healthy lifestyle, coronary disease. And what they did is combine 4 large-scale studies, over 55,000 adults, up to for a follow-up of 20 years. So these are powerful data. What they did is established on each patient from all these studies a genetic risk score, either low, intermediate, or high, based on whether they carried 50 gene variants associated with cardiovascular disease. And then he also looked at 4 lifestyle factors: no current smoking, no obesity, regular exercise, and a healthy diet. They came up with a lifestyle score and a genetic risk score on each one of these patients. They considered favorable lifestyle to have 3 or 4 of these factors, intermediate 2 of those 4 factors, and unfavorable 1 or fewer of those factors. What did they find? Look at this. Everybody you see in this slide was deemed high genetic risk. And what did they find? A favorable lifestyle was associated with nearly a 50% lower relative risk during the follow-up. So here, unfavorable lifestyle, these are all high risk, favorable, unfavorable, favorable, unfavorable, favorable. The 4th study, the bioimage study, looked at coronary calcium and found that both genetic factors and lifestyle factors seem to contribute to the magnitude of coronary calcium. You can see that in this slide. Here you look at genetic risk, low, intermediate, and high. And here you can really see that a difference between those with unfavorable and favorable lifestyles. So here, favorable versus unfavorable for the low, intermediate risk, favorable versus unfavorable, and high genetic risk, favorable versus unfavorable. So the take-home message that I took from this in reading this study further is whether, if we further divide them, and I realize this is a busy slide, but here you see low genetic risk, here you see intermediate, and here you see high. And under each of these subcategories, favorable, intermediate, unfavorable. The take-home message is the biggest bang for your buck in each of these was going from, you can see it here, an unfavorable lifestyle to an intermediate lifestyle. Once again, unfavorable lifestyle for those at intermediate genetic risk to an intermediate lifestyle. Let me go back. And then for the high genetic risk, unfavorable lifestyle going to an intermediate. So if you change just 1 or 2 risk factors, there's a big bang for your buck. Take-home message. Looking at all the data, they concluded bad genes, yes, can double the risk of cardiovascular events, but a favorable lifestyle virtually cuts it in half. In fact, an unfavorable, unhealthy lifestyle erases about half the benefits of picking the right parents. So the deadliest combination, not surprising, you pick the wrong parents and you got a horrible, unhealthy lifestyle. The risk of future coronary events increases 4-fold or higher subsequently. Last study is this one, a blockbuster study published in Circulation 2018. They highlighted in this study that Americans have shorter lifespans, life expectancies, than almost all other high-income countries. They looked at the impact of lifestyle factors using combined data from the Nurses' Health Study, the Health Professional Study, and followed these people up for many, many years. They estimated the impact of 5 specific factors: not smoking, normal BMI, greater than or equal to 30 minutes of moderate intensity physical activity, moderate alcohol consumption, and healthy diet score on premature mortality and life expectancy in the US. What did they find? Powerful data over a 34-year follow-up. Those who adhered to all 5 low-risk factors could prolong life expectancy at age 50 by 14 and 12 years for women and men respectively. What blew my mind was the most physically active cohorts in these studies demonstrated 7 to 8 year gain in life expectancy. So if you say, show me the curves, here are the curves, gain in life expectancy for women, gain for men. Once again, you can see 14 years gained for women who adhere to all 5 of those risk factors, and for men, about 12 years gained for those who adhered to all 5 of those healthy lifestyle habits. Take-home message. Americans could narrow the life expectancy gap between the US and other industrialized nations by adopting healthier lifestyles. Prevention should be a top priority and should be reimbursed, in my humble opinion, more so than it's being done. And preventive care should be an indispensable part of the US healthcare system. To gravitate just a little bit, I'll share with you my 2 cents. There's no country that was hit more devastatingly by COVID than was the United States. I believe, in many respects, this factor, the fact that so many people are obese, have diabetes, have hypertension, that we were really bombarded more so than people in other countries, and as a result, have the current mortality of 530 or 540,000 as of this date. To conclude, what do I want to leave you with? Last 5 slides. As we look at the evolutionary treatment of cardiovascular disease, I started my career in the late 1960s, and we were talking about lifestyle. But then surgeons had the answer. For people with heart disease, we could solve it with bypass surgery. We haven't solved anything with bypass surgery. Pharmacologic therapy, then angioplasty, then thrombolytics, then interventional devices. I would contend that one of the hottest areas right now in medicine is preventive cardiology, which basically aggressively modifies lifestyle and gets patients motivated to do it, and incorporates pharmacologic therapy in preventive cardiology and rehabilitation. My own bias is you don't have to be a psychiatrist or a psychologist to adequately counsel patients. You just need to do a little bit of training and knowing a little bit about what's called motivational interviewing and a readiness to change. Nurses, physiologists can become very adept at questioning patients and getting them using downscaled goals to make substantive lifestyle changes. This is fascinating. Sometimes I learn more from National Geographic than I do some of the big name journals. I oftentimes get the question, who lives in their 90s and hundreds? Scientists have gone in different parts of the world. Sardinians, Adventists, and Okinawans are known for living 9,500, 105, 110 routinely. What differentiates them, and are there, in these long living populations, are there common factors? There are, and they're shown on this slide. Number 1, they don't smoke. They're not breathing somebody else's secondhand smoke. Number 2, they put family first. As an aside, my wife has been telling me for 40 years, family comes first. She's right. She's right. The fact of the matter is there's a health benefit to that, putting family first, being active every day. I'm not talking about having an iPod and headphones and having a $10,000 piece of equipment. These people are moving every day. They keep socially engaged and eat lots of fruits, veggies, and whole grains. I believe there's one thing missing here. And intuitively, and I've been looking at people who lived for many, many, many years, and I believe there's a 6th factor, that they have a very strong purpose in life. That very strong purpose is serving others. I just mentioned earlier Bill Roberts, Dr. Roberts. I just sent him a birthday card, 88. He's still working full time. He's still editor of American Journal of Cardiology and Baylor Medical Proceedings. I said Ken Cooper, Dr. Cooper in Dallas, Texas, just turned 90 2 weeks ago. A birthday card. He's still seeing patients on a regular basis. These are people who are serving others, who have a very strong purpose in life. So in addition to these physiologic, those psychosocial factors, I think, are critically important. Second last slide. If you want to read a devastating editorial, it's this one, New England Journal of Medicine, 2012, titled Moving from Our Reactive Sick Care Model to Proactive Health Care. Basically, they said currently, this was back in 2012, it's higher, it's slightly higher now. Healthcare will soon account for 1 out of every $5 spent. What does that mean? It's 20% of the GDP. 1 out of every $5 spent on everything in our society is going to healthcare. We can't afford it. And we're not outliving many other countries, the populations in most other countries. So we've got to find a way to make healthcare more affordable. And in my opinion, we've got to put more responsibility, not on the physicians necessarily, who are seeing 600,000-800,000 patients a year, but on the patient themselves by incentivizing them to get an annual physical so they don't walk around for 9 years with diabetes. So we know early on what if they've got hypertension and to begin to treat it. And for those patients who are favorably modifying or at least maintaining those abnormal and not getting worse, incentivizing them from a third-party payer system. To conclude, we need to go beyond acute and palliative care. Contemporary healthcare providers, you guys sitting out there tonight, we need to go well beyond treating people in emergency centers, surgical suites, cath labs, hospital rooms, physician offices. Paradigm shift needs to move from not merely treating patients when they're ill, injured, or sick, but helping patients help themselves 24/7. And that's the direction that many kinesiology departments, many exercise science programs, many nutrition programs around the country are increasingly focusing and alerting the medical community that there's more to treating patients with cardiovascular disease than doing 15 angioplasties on one patient, which I saw the other day, which is a crime, or having had 2 or 3 bypass surgeries and still the patient has pain or anginal pain or discomfort. If we can do all these things and be successful, I'm convinced that many of the best years are yet to come. Thank you very much.
Okay. Thank you, Dr. Franklin, for your presentation. I'm going to welcome in my colleague and student here, Isaac Wiedig, who's a doctoral student in integrative physiology. Isaac and I are going to manage the chat. If you do have a question for Dr. Franklin, please go ahead and type it in and we will direct it to Dr. Franklin. And Isaac, I know it might take a minute here for folks to collect their thoughts and put a question. Did you have a question you wanted to start with?
I do have an immediate question here from Josh that we can send to Dr.
Great.
Franklin.
Great.
So Josh asks, what are your views on e-cigarettes as a tobacco cessation aid and risk reduction strategy for cardiovascular events compared to traditional nicotine replacement therapies?
I'm not a fan at all, to be very honest with you. If you look at, it's been studied very carefully by the American Heart Association, American College of Cardiology. Nobody has come out and endorsed this. And there are lots of studies to suggest that vaping can elicit abnormal physiologic responses, some of the same responses we see with cigarette smoking. It's not been proven to be a good way of stopping smoking. So overall, I'm not enthusiastic about it. That's based on the literature.
Dr. Franklin, another question here. This is from Dr. Chen here. How do you evaluate the effect of exercise, moderate versus high intensity, on hypertension and type 2 diabetes?
Yeah, that's a good question. And to my knowledge, those studies have not been done, or if they've been done, they're very few and far between. So I can't say we have a good knowledge base on whether high intensity training would be any more efficacious in terms of people with those comorbid conditions, and it might be worth looking at. That said, I think the program should be done in a medical environment, and ideally people should be monitored, especially diabetics, as he well knows, and hypertensives. If they're diabetic, they're hypertensive, they also got underlying coronary disease. So I also think twice about would the added benefits of high intensity training, especially in an unsupervised setting, really pay for itself. I would probably guess not.
Great. I've got another one here from Josh. Josh would like to know what your opinions on intermittent fasting are as a dietary intervention to lower blood pressure and improve cardiovascular health.
Yeah, intermittent fasting, I was initially a skeptic, but I have some medical students who've opened my eyes, and they showed me there is there is a growing literature that suggests in some people it appears viable, it appears efficacious, and may have promise. I guess that's what I would say.
Next question is from Dr. Ives here. Sorry, my chat feature is jumping. He said, Dr. Franklin, wonderful talk. Thank you. I get a sense that younger and younger folks, for example, 30 years and younger, are exhibiting dyslipidemia. Is there a canary in the mine indicating an upcoming rise in cardiovascular disease?
I think as lipids go, so goes heart disease. If you ask Dr. Roberts, he'd say that's the #1 factor. So from a predictive standpoint, I think it makes great sense. I'd also emphasize that the medical community, of which I consider myself part of, even though I'm not a physician, overall has been lax. And as we look at the standards and guidelines and recommendations, they're only going down because we were too damn high to begin with when we set a cholesterol level 30 years ago. 250 is fine, or 280 is fine, and LDL of 150 is fine. Those numbers keep going down and down and down and down. So I think what's important is to identify people who have lipid abnormalities, to see whether diet, weight loss can help favorably modify that. I will tell you my honest opinion. I think exercise has a lot of wonderful effects, but if you say, Barry, diet or exercise, which is more important? I believe unquestionably it's diet in that particular case. And those who continue to have very, very high cholesterol levels probably should be put on a statin, a low dose statin. You know, you always worry about this. If you're going to put somebody on a statin at 18 or 20 or 20, what's going to happen? And nobody studied it over the last 50, what happens 50 years down the road. But I think the evidence is pretty overwhelming. Just like that picture that I showed of the guy with a cholesterol level of 500, bad things happen with high cholesterol levels over time.
Great. I've got another question here from Dr. Patushik, and he asks, what do you find is the most successful strategy for modifying patient behavior? And where can you go to find training on those strategies?
Yeah, the most successful strategy is you've got to be a good listener to the patient. You've got to be empathetic. You've got to identify what he or she feels are their current obstacles. Sometimes those obstacles, by the way, could be depression, could be financial, could be the caregiver taking care of a mother. I mean, these are all things why people don't get involved in these kinds of programs. Motivational interviewing, readiness to change, very, very important. And probably most important, using downscaled goals. I'll give you my 2 cents on this. The guidelines come out, ACSM, AHA, they say you got to do 30 to 60 minutes of exercise. That may be true, but that's a very bad thing, in my humble opinion, to tell a guy day one, you need 30, which sounds like he's doing nothing. And oh my gosh, how am I going to do 30 or 60 minutes? So downscaled goals for beginners, very, very important. Remember a physics principle. A body at rest tends to remain at rest. A body in motion tends to remain in motion. Our job in counseling patients is to get them started. So when a patient says, what should I do? I don't tell them 30 or 60 minutes like the guidelines say. I say, what are you doing now? He said, nothing, 0. My answer is, can you give me 10 minutes 3 times a week? Yeah, I could, but that's not, give me 10 minutes 3 times. I'll run into guys like this 6 months later and say, Doc, I didn't listen to you. I said, you didn't give me 10 minutes 3 times a week? Well, the first day I went out and did 12, and then the next week I was doing 15, and now I'm doing 45, 5 days a week. Get them moving. Get them moving, you build momentum, and that gets people on the right track. Don't worry about the guidelines. Get them doing something. Ideally, if you can get them doing it with somebody else, the camaraderie, the socialism, the rapport, all those things help. Also, if you can, make it fun. We started playing volleyball at Beaumont. We allow one bounce of the ball per side. Whoever invented volleyball would turn over in their grave if they saw how we played at Beaumont Hospital. One bounce, but we could take people who are overweight, uncoordinated, unfit, and make them an instant success because they don't have to run. They can let it bounce and just hit it back over. So make it enjoyable, modify things.
I think we have time for just a couple more questions, Dr. Franklin. Here's one coming in from Dr. Betts at Central Michigan University. He said, Dr. Franklin, have you read anything about the role of the gut microbiome and how that might be due to cardiovascular disease, diabetes, or hypertension?
Yeah, I read a little bit. There are data to suggest that the gut microbiome may be an indicator for subsequent problems, most notably certain heart problems like atrial fibrillation. I'm working with a very talented electrophysiologist, cardiologist here at Beaumont, and she thinks the horizon, that's where the horizon is in terms of detecting people who are headed for trouble. And by using lifestyle, we may be able to use indicators or markers at the level of the gut to be able to predict who's going to best improve, who can avoid atrial fibrillation and so on and so forth. So I agree with Dr. Betts, who's a friend and esteemed colleague, and certainly would simply say that's an emerging area that is being, we're seeing more and more papers on it right now.
We don't have any more questions in the chat right now. So if you have one, throw it in the chat. In the meantime, I have one for you, Dr. Franklin.
Sure.
Can you talk about like the effect of weight loss with diet versus like food quality? Like, for example, let's say, you know, somebody's food quality is really poor. They eat, you know, a couple bags of Skittles a day, but they're in a negative energy balance, so they're losing weight. Can you just kind of talk about the role of food quality kind of independent of weight loss?
Yeah, first of all, I think unquestionably the literature says by incorporating exercise, we target fat stores to a far greater extent than the lean body mass, which oftentimes comes down with diet alone. So you want the optimal changes in body composition. Something we haven't talked about is if you want to lose weight, I think you got to start pumping iron. I think you got to do some resistance training. Believe it or not, and I've studied this, aerobic training does very little to improve lean body mass. You really need resistance training as a complement, and we showed basal metabolic rate is increased to a greater extent with resistance training than it is with aerobic exercise. Also, caloric restriction and healthier foods. My 6-7 servings of fruits and veggies. Water is a wonder drink. All those things over time, and I typically recommend half a pound to a pound a week to try to lose. That's it. So weight loss. So if they're losing 2 pounds a month, something along those lines, I think that's legitimate and doable. But once again, I would incorporate resistance training, and they gotta move more. Increased lifestyle physical activity in addition to structured exercise. Good question.
Dr. Franklin, we have one more question. I think this is a good one to wrap up on. The background here is you briefly mentioned the COVID-19 pandemic and how it's impacted us immediately here in the United States, even more so than some other countries around the world. The question here is, would you care to speculate about the long-term impact of the pandemic on things like physical inactivity, obesity, cardiovascular disease, specifically here in the US?
Yeah, in fact, the booklet that you were nice enough to highlight was written because of the pandemic and lifestyle. That booklet, your infographic, which both of you were nice enough to let us use, basically, correct me if I'm wrong, but there was about a 30% increase in sitting time according to your study or their studies with your simulation of the literature, 30% increase in sitting and a 30% decrease in physical activity. So the ramifications of that are huge. What's really increased is we've got to get beyond the typical group program where people drive and exercising with others, even though it has advantages in terms of medical supervision, camaraderie, to offer virtual types of things, via exercise-based cardiac rehab, and being able to answer questions on heart rates, perceived exertion, and so on and so forth, to make physical activity, a healthier diet more accessible to people. And I think that's going to be the direction of the future. And I think you'll see a lot more of these kinds of programs. Our hospital, to be quite frank with you, did not have a virtual program. It does now. Yep. There's no question we're going to be able to reach out to people just like we're doing here tonight with that. And to me, that's really a key. So we learned a great deal from that. We've got to be able to continue to motivate patients via lifestyle, via healthy eating, no cigarette smoking. And I think a lot more will be virtual.
Well, thank you, Isaac, for helping me manage the questions in the chat. I really appreciate it. And then please join me, everybody, in giving Dr. Barry Franklin, again, a virtual round of applause for that excellent presentation and taking time to visit with us here.
Thank you, Steve.
Yep, I will go ahead and formally stop our recording here. That ends our public lecture. I know there are a couple people that might want to say hello. So Dr. Franklin, if that's okay, we'll just go ahead and unshare the screen here at the end, just so people, we get that social connection and can wave goodbye if that works for you.
So hit stop share.
That would be perfect. Yep.